You should know that the taxes exceeded by the kidneys, but if you had a farm, you already know that. In terms of fluid balance, it's recommended that the average adult take in 2 to 3 liters of fluid per day. You should know that number, 2 to 3 liters a day. You should know how much urine the kidneys put out, or the minimum you need to see every hour. How much is that? 30 milliliters, but the average kidney puts out 30 to 50 milliliters per hour, depending on how much you're taking in. On homeostasis, that was just a review slide, because you're going to have another module on fluids and electrolytes. There's a slide that says fluid volume deficit. Not the etiology, but the deficit. You should know what the assessment findings are if someone has dehydration or fluid volume deficit. So they would have decreased skin turgor. It might be more than 3 seconds. They have those sunken eyes, dry skin and mucous membranes, and have a dry-looking tongue. They will have postural hypotension. What is that? They have decreased blood pressure when they stand up because the legs fill up with the blood and then there's less to go around. If they're dehydrated, they have less volume. You should know that with less volume, the heart rate goes up as well as the temperature goes up. Okay. They may have extreme thirst. If you're younger, older adults do not experience thirst, and so they might have a sign and symptom of confusion, change in LOC, level of consciousness. They would have apprehension, confusion, weakness, decreased urine output, and they would have increased specific gravity of the urine. Okay. That fluid volume deficit lab findings, you should know that, because I think there's a question that gives you values of increased, whatever, decreased, and then you should be able to identify the fluid volume excess or fluid volume deficit. So with fluid volume deficit, you would have increased sodium, hemoglobin, and hematocrit because the blood is more concentrated, and BUN. Those are the numbers that you should know that they're all increased, okay? The fluid volume deficit has nursing diagnoses. Then you have fluid volume excess. Okay? And the slide that says assessment findings. You should know that if you have fluid volume excess, you gain weight and you more than likely have dependent edema. And generally it's pitting edema. If you have fluid volume excess, especially in older adults, their hearts can't accommodate all of that excessive volume that's coming back to the heart, so they would have dyspnea and crackles because the lungs fill up with fluid. So if you have fluid volume excess, you have too much volume in the vascular system, so your sodium would be low, BUN and hematocrit would be low as well. So hemoglobin, hematocrit is just the reverse of too little fluid. Okay? The best indicator to determine if someone has fluid volume excess, the best indicator for the success of the drugs that we're giving in, some sort of diuretic perhaps, is daily weight. Okay? If the patient has weight gain or loss of 1 kilogram or 1,000 milliliters, it's equal to 1 kilogram. Okay, so 1 kilogram equals 1,000 milliliters. So if they lost 2 kilograms of weight in one day, they have lost 2 liters, 2,000 milliliters of volume. If they increase the weight by whatever, 1 kilogram, they have retained a liter of fluid, or 1,000 milliliters. Does that make sense? So you should know those numbers. Signs and symptoms, if you have fluid volume excess, you would have labored breathing, because their lungs are filling up with fluid. This is where you would have the 3+ bounding pulse. They would have distended neck veins. Increased heart rate, compensating for all that excess volume, trying to keep up with all of the volume that's coming back. What do you think happens to blood pressure? It goes up. For loss of fluid, it goes down. The blood pressure increases with fluid volume excess. And the skin will be pale and clammy, and the patient may be restless as well. So what are we going to do for fluid volume excess? Do what? Diuretic. Give them diuretics. What else?
Maybe fluid restriction?
Fluid restriction. And what kind of a diet might they be on? Low sodium, or very restricted on their sodium. Okay. The other slides go through the psychosocial system needs. You need to know those, not so much for the test, but every concept map that you do, you need to focus on what stage your patient is in, and then you have to make a statement as to what makes you believe that they're in that stage. So there are 8 stages. The ones that we are dealing with primarily are adulthood, 25 to 65, and maturity, senescence, 65 to death. So you should know generativity versus stagnation, which is 25 to 65 years of age, and then integrity versus despair. So you should know what that sounds like, how the patient might describe that, and how you would identify if they're in the negative or the positive resolution. That's all you need to know on that. Yeah? Okay. I'm going to start with module 3. Can people still see if I turn these lights off? Okay. So we're going to start with module 3. In module 3, you're dealing with the older adult. All of us, I think, have done an assessment now on an older adult. I read something in the paper last week about how your trip to Geezerville is non-returnable. You can't come back from it. Everybody is, from the day you're born, you're headed towards Geezerville, it said. Oh, well, isn't that exciting stuff? So we're going to look at some of the changes that occur when we're dealing with older adults. I like this little slide. It says it's important to have a twinkle in your wrinkle. So just because you're getting older and wrinkles doesn't mean you can't have a good time and still enjoy life to the fullest. Okay, there are 2 reading assignments that I have for you. I have a tendency to take a couple of questions from these reading assignments. The first one, you have this slide, right? You should be able to get these through the Neely Library online, going to, I think it's, what's it called, journals and whatever. So don't pay for it. Just go to the Neely Library online. So Colin, Recognizing the Face of Dehydration, Nursing 2011, the August issue, and then the other one is Caring for Older Adults After Surgery. Once you get to acute care, many of the patients you're going to be caring for maybe right after surgery or pre-op, but many of the patients you're caring for now are in the long-term care because they had surgery. They had hip or knee replacement, or they had some sort of an issue that has now required them to be in a continuing care facility. Okay, so what's the definition of the golden years? Sometimes those golden years are not so golden for a lot of people. I think we've discovered that. Many of the patients who are caring for, their life and those years are not so golden. Why are they not so golden? They have health issues. If you don't have your health, you've lost a lot of your ability to be an active participant in everyday living. What else? Why is it not so golden besides the health? They're dying? Yes, they have lots of losses in their life. People are dying all around them. Their friends are dying, their family members, their spouses. So, oldest 20 years older than what I am was a quote that I read in one of the books, and I can't remember where I saw that. But my aunt certainly was reflective of that. I have an aunt who comes here, well, was coming here every year, but now she fractured her hip. I'm not sure she's coming this year. But she would be driving the seniors. The seniors, she lives in the Netherlands, and the seniors would have these outings. And when she was like 75, she would tell me she was taking the seniors on an outing. I said, is that right? I said, so what are you doing? She goes, well, I drive, and I take 3 or 4 in my car. And I said, so when are you going to let someone drive you? She said, when I'm old. I said, so 75 isn't so old yet. She goes, no, 75 isn't old. But one of my students in the rehab facility, I was talking to one of the patients that was assigned to one of my students, and she said something about sometimes she participates in activities, but she really doesn't want to do all that stuff with those old folks. I don't know how old she was. I think she was in her 70s as well. I think she said she was 75. So even though we, from our perspective, certainly some of you being very young, it seems very old when you're 75. But some of those folks are very much like, oh, I don't want to play bingo with those old folks. So old is 20 years older than what you are. We classify people who get older in a number of categories. I like this one too. You can't help getting older, but you don't have to get old. So if you like to kick that old soccer ball around, probably keeps your bones strong. Okay, some of the categories of old. The young old, 65 to 75. The old, 75 to 85. Old, 85 to 100, also called frail elderly. And then you have the elite old, over 100 years old. So I think most of us know people in all of these age categories, right? Do any of you have relatives who are over 100? Good deal. That means you have good genes. Yeah. Okay. So over 100, we're going to see more and more people over 100. One of the senior centers where I go, where we take students for a well elder, there's a little old lady who is, I think she's 103, and she comes in and she takes a little bus in and does exercises, flips around, has no time sometimes for a student to interview her because she needs to go and do this and do that and go shopping and meet friends to have tea, and she is just a hoot. So I believe she's 103. Very, very active, doesn't drive anymore, so she takes the local, what's that senior transportation called, Access Plus? Whatever. So we are all headed towards, hopefully, all of us will head to the elite old and do so in characteristic good health. That's, I'm sure, everybody's goal. It's what? Like that article said, we're all headed towards Geezerville, a one-way ticket. So demographics, people are, in fact, living longer. At the turn of the century, does anybody know, at the previous century, in 1900, between 1900 and 1930, what do you think the average lifespan was? 100 years ago. In the 40s, average. Yes, can you believe that? Although a lot of people did make it to a lot older, but on average, people were lucky to live to 50 when Social Security was instituted in the 50s? I'm not sure when that started. 60s, early 60s, I don't know. But at that point in time, the average person collected Social Security for a year before they died. And so now people are living to be well beyond 65, 66, and that's why they're looking at, how we're going to deal with all these people who are becoming eligible for Social Security retirement. The number of minority elders is increasing. I know here in California, and if you look in the nursing homes, some of the facilities where we go have units that are focused on Korean patients. They have a unit for Spanish-speaking patients. They have units for Vietnamese-speaking patients. So they're trying to accommodate these older adults in long-term care by placing them with cohorts who speak the language and have staff that speak their language. The fastest growing subpopulation are the Hispanic population here in Southern California. Women have longer life expectancy than men. Men are more likely to remarry than women if they lose a spouse. Why is that? They need someone to care for them, is that what you're telling me? That's part of it. What's the other part?
There's more women.
There are more women than men, so it's easier for men to find a new partner than it would be for women. There's a shortage of men. Okay, we'll go with that.
Call me.
Usually when people retire, they have lower incomes. Most live in community settings. We may think, well, we're in long-term care, that when you get old, you end up in a nursing home. That's really not so. The majority live independently for a long, long time. And I think most people live independently if they get to that old stage to be independent, the majority in the U.S., to at least 85, where they live in their own home and they're independently caring for themselves. Okay, another happy couple here. Love doesn't make the world go around, but it makes the ride worthwhile. They've also found in a lot of studies that older adults, especially couples who've been together for a long time, their health seems to be better than people who are single or who've lost their spouses. So having another partner to share your days is very much positive influence on your health. Okay? So what are some of those characteristics of older adults? Chronic health problems and disabilities do increase with age. 73% of older adults rate their health as good, very good, or excellent. So that is amazing. That's a wonderful number. And then 20% report disability, and most have some sort of a chronic disease process. We're looking at lots and lots of big numbers in the near future. So in what, 15, 20 years, the population of older adults, 65 and older, is expected to reach about 71.5 million. So by 2050, elders in our population are projected to outnumber young people. That's a pretty amazing statistic. That'll be the first time that has happened since our country was founded, mostly because of the increasing age, decreasing birth rate. So what does that mean for people who are, if you have more people retired than young people, what does that mean for just in general health insurance, Medicare, Social Security? Where are we going with this? It's not good, because I think when Social Security started, there were 8 people working for every person getting retired. And I think right now it's 2 to 1, and pretty soon it'll be 1 to 1. So each one of you can't pay enough out of your paycheck every month to pay for one person to be retired. So I'm sure all that whole mechanism of funding will probably be looked at in the next 10 or 20 years, I would think. There are lots of theories of aging. There's a lot of research going on too, and a lot of research is focused on what causes us to age, but they found that there is just no single cause of why we get older or why all of our organ systems start having issues with functioning at less capacity than when we were young. But there's an awful lot of research going on trying to keep us healthy for as long as possible. There's a whole list of theories of aging. I have a slide on each one of those. So taking a look at the genetic theory, and basically what that genetic theory says is that the aging process is governed by, in general, by genetic makeup. and that humans are genetically programmed for a predetermined number of cell divisions after which the organism dies. Who was it that had family over 100? You did. You know, it's kind of like the luck of the draw. If you have good genes and most of your family members live to be 100, then chances are you will too. But there are family members in which people seldom make it past 60. And there are families in which the men may not make it beyond 50 because they drop dead from a heart attack. And I think some of us know families like that. It's kind of like, wow, they died so young. I think a good example of someone who was in really good shape was that runner. Fisk? Was his name Fisk? I can't remember his name. But he was, you know, on the cover page of Running Magazine, and he was this distance runner. And I think he dropped dead from a heart attack in his late 40s. Fisk? Yeah, Jim Fisk. So, I'm sorry? So, it's just a matter of, you know, if you have good genes, that's wonderful. My grandmother made it to 98, my dad's mother. But she had 4 sisters who lived to be 103 to 104. And they were born in the 1880s, so they made it for a long, long time. So, hopefully, those of you have good genes. And then there's wear and tear theory, that the more you use it, the more it wears out, and that because we use our bodies to function, that wears out due to a number of things, including exposure to internal and external stressors, including trauma, chemicals, and buildup of natural waste. Continuing with some of these theories, some of the biologic theories, environmental theory is that factors in the environment bring about changes in the aging process. So if you're exposure to industrial carcinogens, if you have daily exposure to just being in the sun, outdoors, everyday working, trauma, infection, all of those things can cause the body to age. Then there's the immunity theory. And the immunity theory basically says that as you get older, the immune system reaches an inability to respond and to distinguish its own cells from foreign cells and attacking and destruction of cells. So older adults don't have significant elevation of white blood cells when they get sick. And that's why often we'll see older adults coming in with like urinary sepsis. They didn't know they had a UTI. They really didn't have a great sense of discomfort when they were urinating and didn't realize they had a UTI. And then they get really sick. They really don't get a fever, but by the time they come to the hospital, they have urinary sepsis. So that's because their immune system doesn't really recognize some of these invading organisms. Another theory is the endocrine theory, and that proposes that events that take place in the pituitary and the hypothalamus are responsible for decreased hormone production that results in your body's decline. The free radical theory, so you can see all these theories abound, but we really don't have a single cause that's been found that causes people to age. I think just recent studies, they did find a gene that when it's damaged causes the aging process, but they're not quite sure what causes it to be damaged, and so the research goes on. Then there are psychosocial theories. The first one is personality theory, that whatever you are when you're a young adult, you continue to be when you're an older adult. So if you were introverted as a young adult, you will continue to have that type of personality. Developmental task theory basically says that's the Erikson theory comes in here, that there are certain tasks that need to be accomplished at specific stages in life, and that you continue to move on to the next level in order to achieve successful aging. Okay? Some other psychosociological theories, disengagement theory, and basically that theory talks about that we need to, as people get older, you need to withdraw from whatever role you may have had in society so that others who are coming up in the system can take your place. So the disengagement theory, an example of that is, for example, airline pilots. I think they have to retire when they are 60. And for health reasons, I'm not sure what, but the thought always was that, you know, that co-pilot's been sitting next to the pilot for many, many years, and that co-pilot needs to have a turn to become the pilot. That's this theory, so that you need to move over, retire, so that the next generation can have that spot. Okay, activity theory basically is that if you stay active, if you don't use it, you lose it type of theory. So activity theory, the more active you remain, the more healthy and successful you will be at aging. And continued mental and physical activity maintains your health throughout the lifespan. And I think that is so true when you start seeing those well elders. Continuity theory, that people maintain their values, habits, and behaviors in old age. So you remain to be the same person that you've always been. Your basic personality doesn't change. So what happens in terms of when retirement comes around? What type of psychosocial changes do most of the older adults have to deal with? First of all, retirement is some people are so shocked by retirement that they don't last very long. I think all of us have heard of people, well, they just retired and now he died. Their whole life purpose is gone. They don't know what to do with themselves. They get depressed, so sometimes those people don't last very long, unfortunately. There's, for the most part, significant economic change. You have the positive of grandparenting, although we have a lot of grandparents who are raising grandchildren. So they have that added responsibility then during their retirement. Often relocation. Why are they relocating? They want to do what? They're in nursing homes. Very few are in nursing homes, but often at retirement they do relocate. They sell their homes. They may not need that 4-bedroom house anymore.
Move back home.
Sometimes if they do have illnesses, they move back home, or the adult children insist they come closer so they can keep an eye on them. Anything else? They're at the age when spouses have died, perhaps, and they are relocating because they're no longer wanting to live in that same place, perhaps. Maintaining independence and self-esteem is very important, and facing death and grieving is something that, as people get older, they'll have to face and deal with. Okay. This is that Erickson, ego integrity versus despair. People who are in ego integrity, when you do your well elder interview, there's a question about what has your life been like, and a lot of people will answer, you know, I've had the best life ever, I have done everything I ever wanted to do, I've traveled, I am just good to go. Then there are those people who despair, and that means that they look back on their life and they wish they could live it over and do a better job of it. We've had patients in the past who were just so depressed, they got a diagnosis that they didn't anticipate, making it pretty clear that they wouldn't have long to live. And then they would have this despair in the conversation that we would have with them after they got the bad news. I wish I had. I wish I had we had one patient who said he couldn't stop crying, and so we were trying to figure out, you know, what could we do to comfort him? And the diagnosis hit him hard, but his immediate response was, I wish I had. Now I'm dying, and I wish I had. And he had some real specific things that he shared, like, I didn't go to my dad's funeral because I was too busy working. I didn't take the time. He missed his mom dying. He knew she was dying, but he was just too busy with family and kids. And so he had all these, I wish I had put more priority on that and had actually been there for my parents. Now I'm dying, and he sort of anticipated that his kids probably wouldn't come during his last days. He probably would show up for a funeral. So he was very, very sad that he had not kept close contact with his siblings, that just lots of things. His whole life was kind of like, I always worked, and working was my focus, and I never focused on the people in my life. He was almost inconsolable, so very much in the stage of despair. Okay, I think I've already pretty much gone over this, 65 to 75, the changes that you have to deal with. And then 75 and older, even more adjustments. One of the biggest adjustments is living alone. The possibility of moving into a nursing home or assisted living is very common at that age for people who have multiple chronic illnesses. They have to face their own death, that at some point in time they need to make preparations for the end of their own life. Safeguarding physical and mental health, remaining in touch with other family members, and finding meaning in life. The people who age most successfully have meaning in life. They have family members, they have friends, they have activities, and even though they grieve the loss of perhaps loved ones, they then put that sort of aside and life goes on type of thing. How about cognitive development? What do you think? Does intellectual capacity diminish over time? Yes? No, intellectual capacity does not diminish over time with normal aging. The older adult does process things a little slower, so if you ask them a question or if you're trying to teach them something, give them plenty of time to process what it is they need to retain. And the ability to retrieve information is slowed down, but the cognitive capacity remains intact. If there is any sort of cognitive decline, if they have a decline in perception, attention span, in memory, that is always an abnormal aging process. Losing your memory is not a normal part of aging. So maybe processing things a little slower, but confusion, all of those things are not part of normal aging. And a real positive statement here, most older adults do not experience cognitive impairments, and they remain intellectually active and intellectually intact. Good news. A little bit about moral development. Moral development is completed in the early adult years at Kohlberg conventional or pre-conventional level. You have to hit the Kohlberg on every one of the concept maps that you do. They do have the value and capacity to modify their beliefs and values, and then their own life experiences influence the values they have when they get old as well. Okay, spirituality is important for many people, but especially when they get older. Why is spirituality important, an important component of aging?
Because these are getting closer to their maker.
Yeah, they're getting closer to their maker. They may not have had enough time, perhaps they didn't have as much time as they would like to have devoted. And keep in mind that spirituality and religion are not the same thing. A lot of people are very spiritual, but they may not belong to any sort of organized religion. You will come across lots of older adults who will mention to you, because they are sick and you are caring for them, they will mention that if they didn't have the religion, they don't know how they would cope with some of the life changes that they're trying to deal with. So they find great comfort in whatever their religious beliefs are. And we need to support that. Okay? So we're going to look at the general effects of aging. So we're going to go into each one of the systems separately, but the process of aging affects every single system. The process of aging is called senescence. Okay, you should know that word. The process of aging is called senescence. Okay? And keep in mind that even though there are lots of physiologic changes, those physiological declines for every system are independent of disease. Everyone, as we get older, has system changes and the effectiveness of how the system functions. So just because there's physiologic decline with aging doesn't mean that they are diseased. So disease processes are independent of the physiologic changes in aging. So this is just sort of a highlight of what we are most often familiar with. We're going to look at each one separately. So age-related integumentary changes. There is less subcutaneous fat. The skin is much thinner. Have you noticed how fragile the skin is on some of your older adults and how easy it is by just turning them to result in skin tears? So be very careful with their skin. Is their skin real moist or is it dry on the dry side? Yeah, the skin dryness, there's a decrease in the function of your sebaceous glands, there's a decrease in tissue fluid and a loss of subcutaneous fat. And because of these skin changes, they have impaired thermal regulation. So why do they have impaired thermal regulation? What does that subcutaneous tissue do? It's a layer of insulation. So that layer of insulation disappears. And if that layer of insulation disappears, what goes with it? So what? Your body heat. But what disappears with that? What's in that subcutaneous tissue? Glands, sebaceous glands. What else? The adipose tissue. And as that disappears, so does the blood flow. Those little capillaries that were nourishing that subcutaneous tissue. And so then they lose their sebaceous glands and they have loss of thermal regulation. They do not maintain body heat as effectively as younger adults. They can't recognize if they get really cold. They don't recognize how cold they're getting. And in heat, they can't sweat to reduce their body heat, and they're at risk for hyperthermia as much as they are for hypothermia. That's why when we have really hot weather, they'll say watch the seniors, and they'll have cooling centers at the mall where they can go and stay cool. Or in the winter, watch out for your neighbors to make sure their heat's on, because they don't really sense how hypothermic they may be getting. Hair may become sparse on the head. It may lose its color, loss of pigment. But hair may thicken, like nose hair, ear hair, where else? Eyebrows start to thicken and sort of get unruly. So you end up with hair where you previously really didn't need it nor want it, but the hair on your head starts to thin out. We have baldness. A lot of men become bald. Male pattern baldness, they call it, but a lot of women, if you look at their hair, becomes very, very thin, very sparse. They have many skin lesions that may have already been assessed by you when you looked at their skin. Did anybody see any of those skin lesions, those age spots? What do they look like? They look like freckles. Okay. What do those hemangiomas. Little bright red spots, often on the trunk. And those start developing when you're in your 30s, believe it or not. But they become more prominent in your 40s, 50s, 60s, and as you get older. Skin tags, just extra little skin tags that appear mostly on the chest again and on the neck. Actinic keratosis. What is that? That's thickening of the outer layers of the skin. Does anybody live near the beach or go to the beach frequently? Have you ever seen older adults who you know have probably lived there all their lives? What does their skin look like if they're wearing much? Very leathery, very alligator looking. I think that might be a good description. So chronic prolonged exposure to the sun, that's called actinic keratosis. Very thickening and scaling of the outer layers of the skin. And then what is seborrhea keratosis? That was one of the things listed in your book as well. Those are raised tan to black, looking like warty kind of lesions, like little warts. They're often seen on the face, the neck, the chest, and the upper back. Okay, so what are we going to do in terms of nursing interventions, caring for older adults? We need to maintain their healthy skin, so ensure optimal nutrition and hydration. So important. How much fluid should they be taking in a day? 2 to 3 liters, right? Why do older adults not drink that much, for the most part? Many of them believe that because they already have issues with incontinence, the more they drink, the worse it gets. The opposite is actually true. What else? They don't have that thirst sensation, so they have to be told to drink water. They do have those water stations in long-term care. They bring water fluids around, but did you see how many cups end up being collected at the bedside and they're not drinking it? So if there's an identified need for more fluids and you're caring for them, see to it that they drink the Boost or the juice, whatever is at their bedside, because they start collecting and pretty soon somebody sweeps them off the table into the trash and they're gone until they start collecting again. So there's a reason why they should drink those fluids. So use lotion. Avoid skin products that contain perfume or alcohol because it dries out the skin even further. If they're going out in the sun, they should wear sunscreen. Observe the skin for any sort of skin changes because they are much more likely to develop skin cancer because their skin has had years and years of exposure to the sun. And if they have really sensitive skin, if their skin has sensitivity to like detergents or whatever, then they need to avoid those sort of detergents that cause skin issues with them. What else did you notice about their skin? Anything else?
Sure.
The turgor. Yes, what did you notice? Especially if they already have lots of wrinkles, and then you pinch that little bit of tissue to check for tenting. It should flatten out fairly quickly in older adults. If it stays tented, that's an indicator that they are dehydrated. They need more volume of fluid on board. But for the most part, you will notice that their skin is already wrinkled, so when you check the turgor, it often takes a few more seconds to go away. Oh, you have another slide, don't you? Loss of bone mass? Oh, that's the next one. Okay. Musculoskeletal changes, loss of bone mass or osteoporosis. What causes osteoporosis? What's that bone reabsorption? What's that called? And then there's bones building up. Osteoclast and the osteoblast, right? Okay, so there is more bone reabsorption than there is bone buildup. So osteoporosis may be severe enough that they have spontaneous fractures, severe osteoporosis. So very, very common in older adults. It's in women as well as men. They found that the osteoporosis is more in people of European descent than perhaps from other areas. So what do you need to keep them safe? What should they take to keep their bones strong? Calcium, how much? About how much? 1,500 calcium per day. And how much vitamin D do you think? 2,000. Yes. So you need vitamin D, calcium, and what else maintains bone strength? Exercise. What kind? Weight-bearing exercise. Very, very important. And what's one of the best exercises they can do? Walking to maintain that bone strength. Maintains range of motion as well. There's cartilage degeneration and shrinking vertebral discs. What happens is that the cartilage sort of starts dries out, starts to shrink, and so what happens as a result is the individual loses height. Everyone, regardless of genetic background, loses height, sometimes up to 6 inches by the time the adult dies. So average is probably 3 to 4 inches of height loss for the average person. So that's due to the drying, the loss of elasticity in the joint cartilage that cushions the vertebral disc. A lot of people have osteoarthritis, and osteoarthritis is the joint pain, osteo meaning bone, arthritis, inflammation of the joint due to wear and tear. That's why we see many of the older adults who've had total knee and total hip replacements, generally due to osteoarthritis. So, the next item here. Okay. Also, osteoarthritis can cause decreased mobility of joints because they're painful to begin with. I mentioned the 1.5 to 4 inch loss of height is average, but up to 6 inches is not considered terribly abnormal. But the more osteoporosis you have, the more height you lose. There is muscle atrophy. So the muscle atrophy, after the age of 50, due to a steady decrease in muscle fibers, you have, it's also thought to cause innervation of the muscle, so there's less sensation as people get older, and loss of muscle is called sarcopenia. Okay, so muscle atrophy and a steady decrease in those muscle fibers, sarcopenia, particularly after the age of 50. And because they have muscle atrophy, there is decreased muscle strength, causes them at risk for falling because their balance is affected as well. And if they have osteoporosis, they start having this posture change. What's that posture called as they having their spine starts curving? What's that called? Kyphosis, right? Lower doses of sway back, kyphosis. So that's that stooping posture, looking like they have a hump back. You may see some older adults who are almost at a 90-degree angle, looking at the floor. They can't stand up straight anymore due to severe osteoporosis. So we need to focus on, as far as musculoskeletal system is concerned, on keeping them safe. So in their homes, we tell them you shouldn't have any throw rugs that you can trip over. There should be clear walking space, the path of, the most traffic path through the house, so they can trip over things. Grab bars in the bathrooms for leaving the lights on at night so they know where they're going, so they don't trip and fall, because a fall can result in permanent inability to ambulate again. You want to make sure that they look at their feet when they're walking, if they change surfaces. So if you're going from the curb, from solid concrete, and you're going to start walking on gravel or grass, we tell people to look at their feet to make sure that they're placing their feet on a surface where they can maintain their balance. Okay, neurologic changes. There's a loss of neurons. Brain weight diminishes by 5 to 7%. And that's the loss of neurons also cause loss of nerve conduction. And that's because there's a significant loss of peripheral nerve fibers. So it's not unusual of people, when you check for sensation, that they have very diminished sensation, especially in the lower extremity. And after the age of 40, some of you may be getting close to 40, you lose 50,000 neurons a day. A day, from an initial pool of 10 billion. So there's lots of them. But 50,000 neurons are lost a day. They have diminished deep tendon reflexes. The reaction time is impaired. And that reaction time impaired, we often think of it while they're driving. They can't react as quickly to making some decisions about what's happening at the moment in traffic. They have decreased tactile sense, so loss of sensation, as not as crisp and clear as it used to be. They have loss of sensation normally with age in the extremities. Then if you add diabetes to that, diabetes causes peripheral neuropathy. So many of these older adults end up with no sensation in the lower extremities at all. And very important that we keep them safe because they have an increased threshold for pain. They have decreased sensation of temperature. So sometimes you see older adults coming in and they've been scalded in the bathtub. They couldn't tell how hot the water was. And then when they stepped into it, because their legs, it has diminished sensation, they have peripheral neuropathy, they'll come in with burns on their lower extremities. So one of the things that we tell them, if they have any sort of diminished sensation in their extremities, that they set the water heater not to exceed 110 degrees, so that they will always know that the water won't heat beyond that, so that they won't have scalding issues. And we tell them to use a bath thermometer so that to make sure that if they 110 degrees for your hot water heater isn't very hot. So if you ever want really hot water, that wouldn't be sufficient. So if they choose not to set the water heater at 110, then we tell them to get a bath thermometer so that the washing machine, for example, would still have hot water going to it. They have an increased need for affective touch. So make sure when you take care of your patients, when you come up to them, you hold their hand. When you talk to them, that they have that sense of someone cares. Not everyone has visitors in long-term care, so that need for affective touch increases with age. And so giving them a back rub, holding your hands when you come to the bedside is very beneficial, not only psychosocially, but also physiologically for older adults. Has real positive physiological and psychological effects if you touch your patient. You all know the zones of touch that are acceptable, right? Hands. What else? Shoulders, right? Okay. So the arms, the shoulders, hands. So touch them as you care for them. Okay. More neurologic changes, decreased proprioception, and that means decreased ability to sense where their body is in space. And because they have decreased proprioception, we tell them to look at their feet where they're walking if they transition from one surface to another. They have tremendous sleep pattern changes. As you get older, you end up not having much deep sleep. So younger adults, we're going to learn about sleep later, but they'll have stage 1, 2, 3, and 4. And most of you, that stage 1 is that drowsy stage, and then you transition to 2, 3, 4, goes back to 3, 2, and then REM sleep. But these, as you get to over the age of 55, there's a tendency to wake up every hour, it seems, because every sleep cycle, they go back to stage 1, where they wake up. So some of your patients may say, I was awake all night. But the nurse didn't say anything about it. I may have given you a report that the patient slept all night. But they actually saw the clock every hour on the hour. And then sometimes you forget that you slept in between because you're so focused on, still awake. Now it's 3, now it's 4. Because they lose stage 4 sleep. Deep sleep is not something that many older adults have access to anymore. Okay. We already talked about the thirst response diminishes, so they need to drink even when they're not thirsty. Because they're at risk of dehydration. A little bit about visual sensory changes. There's lots of visual acuity. And they also have loss of hearing. Did you notice how sometimes they have red rims around their eyes and their eyes look kind of dry? Because they lost hearing to keep the eye moist. The loss of visual acuity, the presbyopia. Presbyopia means you can't focus on near objects. Okay, so you can't read without reading glasses anymore. Some older adults will have thickening of the lens that's called cataract. The lens sort of becomes opaque. You may have already checked your patient's pupils and noticed that their pupils are smaller than maybe your family members whose pupils you've been checking to see how they respond. And these older adults have a much smaller pupil to begin with, and it reacts more sluggishly. And it's sometimes hard to see if there is significant response of that pupil, especially if they have really dark eyes. Decreased pupil size and tear production, and they have a need for more light. If you are able to read now and pretty much in the pretty diminished light here in the front row, if you were 65, 70, you would be much more comfortable if we turn the lights back on. My dad lived with us the last 5 or 6 years of his life, and I noticed he always had all the lights on, and he liked to read the newspaper, but he liked all that light, and I never said anything. But they have a need for more light because the pupil doesn't respond as quickly, and they just can see better if you just turn on all the lights. They have increased sensitivity to glare and decreased ability to adjust to darkness. That's why many older adults stop driving at night. You know any older adults who don't drive at night? Maybe grandparents? They drive fine in the daytime. What happens at night? They can't see. Why not? The pupils don't respond as quickly, right? Because we notice that they respond more sluggishly when you check their pupils. They have increased sensitivity to glare because if they're driving, and if you're driving on a road and it's dark, and a car comes at you from the opposite direction, those headlights do what to your pupils? Constrict them because there's more light, and so the pupils constrict. The car's gone, it's dark at night, and what happens? What should happen immediately? The pupil should dilate so you can see. Then they can't see for a while because the pupil's slow to react. The pupil is still constricted. There are no other oncoming traffic, and now they can't see. So that's why they stop driving at night. And they have decreased ability to adjust to darkness at home too. So we tell them to have night lights on. If you are, if an older adult has to get up in the middle of the night to go to the bathroom and they turn the light on, what happens to their pupil? It constricts, right? So they leave the bathroom, turn the light off, they walk back into a dark bedroom. They're essentially, that pupil can't respond quickly to open up so they can see where their bed is, and so they'll stumble and fall. If they have a night light on that has sufficient light, and a lot of the night lights are pretty bright, they don't have to turn the big light on to begin with. And if it's going to their bedroom as well, if they have a night light on, they will not stumble and fall. So the risk for falls is greatly diminished if they use the night light. Often older adults get a partial or complete glossy white circle, there it is, around the periphery of the cornea. There's a picture on the bottom. See that glossy white circle? What's that called? It's called arcus senilis. You should know what that's called. It's a normal part of the aging eye, but you can readily see it. So pay attention on your older adults when you check their pupils and see if they have arcus senilis. By the age of 80, nearly all older adults have vision problems. There are very few who don't have a need for reading glasses, for glasses to accommodate distance. Many older adults have significant loss of vision due to age-related macular degeneration. That's the biggest cause of blindness in older adults. Do you know what causes the arcus senilis? What causes that white circle? Fatty deposits around the cornea causes that arcus senilis. Okay. Progressive loss of hearing, you need to know what that's called. It's called presbycusis. So it's one of the common things when people age. Gradual loss of hearing is more common among men than women. It's the third most common health problem in the elderly, hearing loss. Okay, what do you think is the first biggest problem? Health problem. Hypertension. What do you think is second? Arthritis. And third is hearing loss, presbycusis. Presbycusis decreases your enjoyment of life. If you can't hear what people are saying anymore, you can't participate in the conversation, and you start withdrawing from your circle of friends, participating in the conversation. So pay attention to whether or not your patient has a hearing aid. If they really can't hear you at all and they have a hearing aid, encourage them to put it in. Sometimes it's more annoying to them than to just not have it in. So pay attention to whether or not they have a hearing aid and encourage them to wear it. If you do have someone who doesn't have a hearing aid, or perhaps even with a hearing aid, how do you communicate with them? If they're hard of hearing, they're not deaf, they're not stone deaf, they're hard of hearing. You can write on paper. Often they'll say, I can hear with this ear, but not this one. So then what? Speak into their good ear. So if you're on their bad side, go to the other side and speak into their good ear. Face the patient. Don't be on the side. They need to be able to see you. And sometimes they can sort of, based upon what they think you are saying, by just looking at your speech, they may be able to identify what it is you're talking about. You need to lower the pitch of your voice if someone is hard of hearing, and you need to speak clearly in short sentences. Don't have this long, prolonged sentence. Are you hungry? So you don't have to add to that, because, it's been 12 hours since dinner, and my gosh, here it is, whatever time. Are you hungry? Just don't add to that. Ask simple questions in single sentences. So short sentences are helpful to almost all patients. There's a decrease of the sense of taste, especially sweet, bitter, sour, and salt. Decreased sense of smell, and if you can't smell, you can't taste either. Did you know that? So people who can't smell can't taste their food. The loss of smell is called anosmia, anosmia. And because they have a poorer sense of taste and smell, they're less stimulated by food. Sometimes they'll just look at it and say, I'm not interested, I'm not hungry, because they can't smell it. And then if you do taste it, because you can't smell, it doesn't taste like you expected it to taste. So that's a real problem in older adults, especially in nursing homes. We also, knowing that they can't smell well at home, we encourage them to date stuff in the refrigerator, so that if they can't tell that the milk has soured or the yogurt's no good anymore, instead of eating it because they can't tell and they can't smell it, to just make sure that they adhere to the due date, so they don't eat some science project, right? So labeling and dating of food at the home, very, very helpful. I used to have a neighbor, and I'd come and help and sometimes bring food, and I'd look in the refrigerator and think, oh my gosh, I brought this to her 2 weeks ago and it's still sitting here. And so I'd start gathering stuff and throw it out, and she'd say, there's nothing wrong with that. Oh my God, this smells horrible. But she couldn't smell it, thinking that it was going to be good for who knows how much longer. Lots of pulmonary changes. Lots of our older adults have smoked or are still smokers, because the generation that's now in their 60 to 90 year age group, many of them grew up smoking. So we're going to deal with lots of people who have significant respiratory changes. As far as just overall pulmonary changes, the alveoli diminish, the elastic recoil, they don't pop open as readily as they do in younger lungs, so they have a decreased ability to cough and to expel foreign matter. So their ability to cough is diminished, and then their diffusion capacity is diminished. So there's less effective gas exchange. If you're looking at some of these patients, they may have a nursing diagnosis which you associate with decreased ability to cough and expel foreign matter, and that the what? Maybe impaired gas exchange, but if they can't clear their lungs to cough. Ineffective airway clearance, absolutely. So the goal is for these patients to maintain a clear airway, right? And their large airways in older adults increase in diameter, and the smaller airways decrease in diameter. So you have increased physiologic dead space. Dead space is where no oxygen, no gas exchange takes place. So some of these patients have decreased oxygen carrying capacity because they have low H&H, and then you decrease the effectiveness of the lungs, the alveoli, and you end up with patients who have impaired gas exchange. Absolutely. So the lungs don't expand as well. They have less effective exhalation, reduced vital capacity, and they have increased residual volume, so they have more air that stays in their lungs. Stale air. They have diminished exercise tolerance, so if you weren't short of breath when you're in your 30s and 40s walking up 3 flights of stairs, you might be short of breath after just 1 flight of stairs when you're 70. So they will have dyspnea, perhaps, shortness of breath, if they have to walk continuously without stopping up a flight of stairs. Total lung capacity overall in older adults is diminished by 10%. And then their chest becomes more rounded. And what is that called? They become more barrel-chested, absolutely. So lots of changes. There is increased vascular resistance, and what causes that? What causes increased vascular resistance? What happens when you get older? What happens to your blood vessels? Okay, and what is that called? Okay, so arteriosclerosis is sort of the loss of elasticity in your blood vessels. How does that differ from atherosclerosis? Yeah, atherosclerosis is the buildup of fatty plaque in the blood vessels, but everyone has arteriosclerosis with age. Okay, the capillary blood volume decreases. They have risk of hypoxia. What makes them hypoxic? All those things, right? And what is hypoxia? Hypo meaning less than normal. Oxygen where? In the tissues. Hypoxemia is oxygen in the blood. Okay? Okay, they have greater susceptibility to respiratory infections. They have, as we mentioned, shallower breathing, less effective cough, so more likely for organisms, bacterial infections, whatever they inhale is more readily converted to a pneumonia. The chest wall, there's decreased compliance, there's less efficient gas exchange, decreased chest muscle strength. So these patients have more mucus collecting in their lungs. They can't cough it up. Their immune system is diminished, so you can see why so many of our older adults, we end up with them having respiratory problems. Okay, lots of cardiovascular changes with age. The valve stiffens, so the heart wall thickens, and that leads to decreased cardiac output. So with the heart walls, the heart muscle, thickening and reducing cardiac output, these patients then become at greater risk for orthostatic hypotension as a result of that. Okay, because they have all of those concurrent changes. So they have, in addition to that, they have reduced elasticity, an increased rigidity of the arteries, and what's that called? Arteriosclerosis leads to decreased, what's SV? Stroke volume, and that's the amount of blood pumped out by the left ventricle with every beat. And what's CO? Cardiac output. Okay, so those would be decreased. There's decreased peripheral circulation. The pulses are not always palpable, but usually they are. If you can't find a pulse, what do you have to do? Find a Doppler to make sure there is blood flow, even though you can't palpate the pulse. And so many of the patients whose peripheral pulses we checked had how did you grade them? 1+? They were not as strong as the upper extremity pulses in many cases, right? Which may have been 2+. Okay. We already know about orthostatic hypotension. How much do you think blood pressure can drop from someone who goes from a lying position to quickly standing? 65 millimeters of mercury is possible drop. That's why if older adults need to change position, we need to do it slowly from lying to sitting and then sitting to standing. So give them a chance to equilibrate. And what causes that? Physiologically, what causes that? Why do they have orthostatic hypotension? We already mentioned why. Why? They what? No, they're not laying down too long. What causes that orthostatic hypotension? The pooling of the blood? No. Yes. What happens to those blood vessels? They don't respond anymore. So if you and I stand up quickly, what do those blood vessels in our legs do? You think they dilate or constrict? They constrict to maintain pressure. Older adults have arteriosclerosis. Those blood vessels are not as elastic. They don't respond as quickly. So most older adults do have orthostatic hypotension. And how do you check for orthostatic hypotension? Yes, and how much time do you take to do that? Yeah, if you truly are ordered to take orthostatic blood pressures, they often order the time frame. It's usually 3 to 5 minutes. So allow them to equilibrate, and then after you get them to that position, within a minute you should take the blood pressure again. Okay? What else happens to the heart? The conduction system is less effective, right? And if you have a less effective conduction system, what does it lead to? Yes, what kind? What kind did your patient have? Atrial fib, absolutely. Atrial fib, very common in older adults. And atrial fib means that the heart doesn't have the benefit of the atria contracting rhythmically with the ventricles. So the atria just sort of quivers, and so there's decreased cardiac output. It doesn't have the benefit of that organized filling with blood. So they have 10% of their pacemaker cells left on average at the age of 75. You've lost 90% of your pacemaker cells. Where's your pacemaker? What's the node called? The SA node. So the conduction system has lost 90% of the pacemaker cells. That's why we see so much atrial fib. They often have ectopic beats as well, but probably the most common is that atrial fib. If you have a patient who has atrial fib, what medication are they often on? DIDs to strengthen the contractions of the heart. So what else? Aspirin or Coumadin. Why so? Because the atria just sort of quivering, all the blood doesn't get ejected with each contraction, and so that blood sits there for that split second extra, which will cause the blood to have a tendency to clot. So if that blood has a tendency to clot, and then it gets, after it goes from the right atrium into the left ventricle, it pumps it into the lungs, so there's a risk for pulmonary embolism. And then if it gets through the lungs and out the aortic valve, there's a risk for, if one of those clots goes to the brain, you have a stroke. If it goes to your heart, you have an MI. If it goes to any other artery, you can have occlusion of your, I don't know, the artery that nourishes your kidneys or your omentum, or all kinds of things can happen. So keep in mind that these patients are often on medications, and the purpose is because they have atrial fib. So if you have anyone who is on Coumadin and they have atrial fib, that's the reason. Okay, so many of these older adults have blood pressure because of all of these systemic changes in the vascular system that is higher than normal. So they're hypertensive. How many of you have patients who have hypertensive meds, antihypertensive meds? Many of you, okay? And so now you know the physiologic basis of what's causing that increased blood pressure. At what level do they aggressively start treating blood pressure? Remember the blood pressure from last module? All the pre-hypertension, stage 1. At what level do they start treating hypertension? At 140. And the drug of choice is a diuretic. First line of defense. What else do we do to keep that blood pressure from going too high? What other teaching and changes in lifestyle do we promote? Diet, what kind? Low sodium. What else? Exercise. Yeah, we encourage them absolutely to exercise. What should they also be aware of? Their cholesterol levels.
About not drinking too much fluid?
The increase in the fluid should only be considered not to drink so much if they have congestive heart failure. If they don't have a failing heart, they need to drink 2 to 3 liters of fluid a day. So do not diminish withhold fluid because they have hypertension. Okay? What else? Anything else? What should we teach these older adults about their heart and their diet? So low cholesterol, they should know what their cholesterol level is, they should know what the blood pressure level is, and they should monitor the blood pressure to make sure that whatever treatment they're getting is effective. Okay. The GI system. The GI system has its own changes as well. With aging, the most common is that there is delayed swallowing time. Not that they have impaired swallowing where they can swallow, but the swallowing is delayed, swallowing time. So with delayed swallowing time, your older adults are at increased risk for aspiration pneumonia. Okay? They have increased indigestion, and they often have constipation as well. So if you have slowed or delayed swallowing time, and then you have decreased peristalsis in your gut, right? And your stomach doesn't empty as quickly as it did in the past, you end up with constipation. What is your patient getting to prevent constipation? What's the best thing to give them? Fiber and fluids, absolutely, those 2 to 3 liters of fluids. So they have decreased ability to swallow. They also have diminished gag reflex, normally with aging. They also have decreased saliva production. All of those combined increase the patient's risk for choking. So if they're eating independently, what should we teach them? Eat slowly. Take small bites. Follow every bite with a drink, some liquid. So a bite and a drink and a bite and a drink will encourage them to get some of those fluids in as well. One of the students this week had a patient who had difficulty, had a G-tube, because after surgery, I believe, he couldn't swallow anymore. And in talking to the speech pathologist thought that his lack of ability to swallow, which was returning, was just due to the aging process. So generally, that's not a major issue, but with other things having been performed and surgeries, for a short period of time, that patient had a G-tube because he couldn't pass the swallowing test. They were going to have, whose patient was that? The patient was going to go have a swallow eval.
Actually, he had an overall weakness, all his muscles. He lost a lot of muscles because he had colon cancer.
Yes.
And because after the surgery, he was so weak and he lost so much mass,
Right.
the swallowing reflexes were affected too.
And anyone who is hospitalized, you lose about 10% of your strength per day. You lose your muscle mass very quickly. And of course, those muscles in your tongue, those are muscles that need to be effective in manipulating the food to get it to your esophagus so you can swallow it. So he had generalized weakness that was to such an extent that his swallowing had been affected, but they were hopeful that he could pass the swallow exam and that he could eat again. Some more GI changes. So for constipation, what's the best thing to do? Fiber. Yeah. Okay. So for GI, increased occurrence of hiatal hernia, what is that? What's a hiatal hernia? You'll see an older adult will say on the medical diagnosis that they have a hiatal hernia. The stomach protrudes through the diaphragm into the chest, causes tremendous acid reflux. Okay, so they may have a history of tremendous acid reflux. They may be on medications to reduce that acid reflux. They may have a history of pelvic ulcers. Already talked about the delayed swallowing time. Some of these patients are not eating well either. We talk about swallowing time because they're edentulous. They're without teeth. Anybody have patients who didn't have any teeth? Edentulous. Okay? And then with the reduced saliva production, they end up with a very dry mouth. Did anybody get medication for xerostoma? Dry mouth? Yours did? Yeah. Okay.
I think other people want to cause it gets more crack due to that as well.
Mr. Crack as well, sounds like he was a bit dehydrated as well. Generally, the lips don't really become dry and crack unless they're behind on fluid. But it can be just a vicious cycle. As far as the stomach is concerned, there is decreased gastric acid. So why is that important for you to know? Okay, so there's reduced ability to digest food, but it leads to, this is important for you to remember, it leads to decreased absorption of iron and vitamin B, and what's that called? Did anybody have pernicious anemia? Okay, so in the stomach, there's, do you remember production of the intrinsic factor? Remember that from anatomy, physiology? And that loss of gastric acid leads to diminished production of intrinsic factor, and it leads to pernicious anemia. And the cycle is decreased absorption of iron and vitamin B, B12, due to loss of sufficient amounts of gastric acid, leads to pernicious anemia. Did anybody have patients who was anemic? Many of you, right? Part of aging. So the decreased gastric acid leads to epithelial atrophy. So the GI tract is less protected with protective mucus, and that puts them at greater risk for gastric ulcers. And if they're on low-dose aspirin already or on a blood thinner, they have an increased risk for GI bleeding. So we tell them generally not to take NSAIDs, non-steroidal anti-inflammatory drugs. Okay, and the decreased peristalsis, we need to increase their fluid and their fiber. How much fiber should they have a day? You know about the fluid, 2 to 3 liters a day. How much fiber? 20 to 35 grams per day to keep that intestine going. And it also helps to make them aware that they need to have a bowel movement. Without adequate fiber, those dull nerve impulses make them not aware, and so the stool stays in their large intestine for a longer period of time. Okay. How about the pancreas? What about the pancreas? Decreased lipase production. So with decreased lipase production, what happens? There's decreased fat absorption and digestion, and it may result in steatorrhea. What is that? A lot of fat in the stool, and you can actually see the fat floating. And if they're using the toilet, just sort of a lot of fat globules floating around. If they're using the bedpan, it's pretty obvious that they have steatorrhea. Generally means that it's due to a change in the pancreas' ability to absorb fat and to digest fat. The liver, there is decreased drug metabolism ability with the liver having diminished in its effectiveness. Between the age of 25 and 65, probably the majority of people in this class, you have lost 50% of your blood flow to your liver between the age of 25 and 65. So by the time you get to 65, your liver is functioning at half of what it did when you were younger. Half of its capacity is left. That's important for us to know because a lot of older adults take lots of drugs. And what does the liver do? The liver metabolizes the drugs. The kidneys excrete the metabolic waste, right? So if you have decreased liver function, it can very quickly lead to drug toxicity. So you need to assess the patient for the side effect of all the drugs that they're getting. check for signs and symptoms of toxicity early on. And with older adults, the mantra is start low and go slow. So we start with the lowest dose, and we go very slow, adding increased doses. And we try to not have multi-drugs being given to the patient, but most of them have what we call polypharmacy. The majority of older adults are taking a bazillion meds. How many routine and PRN meds did some of your patients have? 20? 30? Right, 30. How many had 30? Oh my goodness. About 6 of you, 30 meds. Okay, that made you pretty busy trying to calculate the purpose and side effects and all of that. 30 meds. How about less than 10? Oh, some of you, so that's good news that you had less than 10 meds. Okay, so between anybody less than 5? Okay, so it looks like we're somewhere between 10 and 30 meds. 30 meds is huge. So that truly is polypharmacy. Then it's really hard to determine which drug is causing the toxicity. So if the new drug has just been added and the patient has side effects, it's probably the new drug that was just added. So back off on the newest drug. Polypharmacy can be really problematic in trying to determine what is causing some of the patient's signs and symptoms. We need to assess patients for malnutrition. How many of you think your patient in long-term care was malnourished? Yeah, we see lots of malnutrition, and it's pretty widespread in long-term care. If the patient is in the home, it can often be to they're not able to go out and buy food, prepare the food, or once it's prepared to be able to chew the food. Some of them have malabsorption syndrome. What is that? It's not, those nutrients are not reabsorbed where? In the intestine. So malabsorption, which often results in diarrhea or loose stool, which, of course, there's lots of nutrients. Some patients have drug addiction, and so often in older adults, the drug addiction is what? Alcohol. So they'll drink their calories, basically, and they don't have good nutrition, which is sort of a vicious cycle in terms of the individual becoming malnourished. And then, of course, infection. If they're not well nourished, their risk for infection is greatly increased. Which lab tests do we look at to determine if the patient is malnourished? Albumin. If they're in acute care and they're on total parenteral nutrition, what do we look at? The pre-albumin. But the albumin will tell you, in the absence of liver disease, how severely malnourished your patient is. Remember what the normal is? And they're considered malnourished at what level? 2.5 or less, yes. Anybody have a level that was 2.5 or less? No? Okay. Significant problem, malnourishment. Looking at 40 to 60% of people like older adults are malnourished, or there are 20 to 60% of home care patients. But 40 to 85% of nursing home residents suffer from malnutrition. That's huge. When there's around-the-clock care, you would think that those boosts and those high-protein drinks would be administered, but anybody see them just go into the trash? No? Yeah? It's amazing that whoever is assigned to care for these patients doesn't insist or help the older adult to actually consume what has been ordered for them in terms of their nutrition. And then it has what the older adult nutritional requirements are. You need about 30 calories per kilogram. If you wonder how much nutrition you need, if you weigh 100 kilograms, you're fairly, that's almost no, that's too big. 50, how about 75 kilograms? That's about 160 pounds, I think. So how many calories do you need then? 30 calories per kilogram.
Like,
What's 75 times 30? I mean, yeah, I said 75 kilograms. Yeah, so that's how you can sort of, by rule of thumb, determine if your patient's getting enough nutrition. Okay? Some of the reasons for poor nutrition. Going on to the genital, urinary, and the renal system. What do you already know about changes with aging? What happens to bladder capacity in older adults? Is it increased or decreased? It's decreased. So bladder capacity is decreased because there's loss of adequate muscle tone to the bladder. What happens to the sphincters? They relax and they become weaker. Did anybody care for someone who's incontinent? Bladder incontinence, okay. The glomerular filtration rate in your kidney after the age of 30 decreases by 1%, 1 to 1.5% per year. When you look at all this, it's like, oh my gosh, will I even get to Geezerville? Right? So 1 to 1.5% per year after the age of 30. So if any of you thought that you start aging at 65, the process begins, the decrease in function of various organs starts early on, some as early as 25. Okay? There's a 1 milliliter per minute per year decline in creatinine clearance after the age of 40. You don't have to know these numbers, but just know that this isn't happening boom at 65 and suddenly things slow down. So the creatinine clearance is diminished significantly. Urine concentration at the age of 80 is 70% of the value of someone who is 30. Okay? So as a result, there's decreased renal metabolism and clearance of medications and metabolites. They stay on board longer because the kidney takes longer to be able to excrete it. And just to give you an example, if a young person takes diazepam and they both take the same dose, the younger adult, the half-life is 24 hours for that drug. The older adult, over the age of 50, it takes 72 hours for that drug to be excreted by the kidney. So you're looking at 24 versus 72. That's why with older adults, we try to start with lowest dose possible before we increase it, because all of those drugs stay on board much longer than in younger adults. Some of the patients get fentanyl patches for pain meds, long-term pain management. For a younger adult, it takes 250 minutes for the half-life. In an older adult, 925 minutes. So you're looking at almost 4 times the amount of time to get to that half-life. So patients can very readily become toxic or overdose. So if they start having LOC changes, look and see what side effects some of these meds have. Kind of depressing, huh, to know that things are just going south at such a young age. Okay? So the decrease in blood flow, glomeruli, renin, and filtration system, and that's because you have 50% fewer nephrons and 50% less renal blood flow at the age of 65 than you had at the age of 30. 50% less perfusion to the kidney. There is a decrease, I just mentioned, a decreased creatinine clearance, poor response to stress. There is urinary urgency and frequency. In older adults, 17% of women and 11% of men have urinary incontinence. And questions, I don't ask you percentages, so don't memorize this kind of stuff. Just know that it's not uncommon. 17% of women, 11% of men over the age of 65 have issues with incontinence. This is something you should remember. If you are working with an older adult or a family member and they've been continent all along, they don't have issues with incontinence. Remember, normal older adults are not incontinent. They're not, impaired in terms of their cognitive ability, that sort of thing. So if you have a normal adult, an older adult who is normally continent and they become incontinent, it's one of the first signs of a UTI. Important for you to remember that, because we get so many patients who come in with urinary sepsis that if the family members or if the patients knew that if they suddenly lose the ability to be continent, they should probably go to the physician and check to see if they have a UTI. Keep in mind that as you get older, incontinence is never normal. It's always an abnormal part of aging, not a normal part of aging. Okay, what kind of muscle, should I call them, exercises can you do to strengthen Kegel exercises, to strengthen those pelvic floor muscles to increase continence? Okay, so how much fluid are we going to give these folks a day to maintain urinary continence? 2 to 3 liters a day. To keep them safe, don't give them diuretics at night. They don't have to get up. So if you're reviewing their meds at the time of discharge, make sure you tell them. And often we tell them what time to take it. Do not take these diuretics at night. It's going to be up and around all night long, up and down, every hour or two. So they need to do that during the daytime so that they don't fall in and lose the whole night's sleep. What are some of the foods that can irritate the bladder and increase incontinence? Caffeine, big time. So if they've never had incontinence before, we tell them to cut out sugar and caffeine, as well as alcohol and any sort of spicy, acidic foods. So to prevent incontinence, lots of fluid, even when they don't feel thirsty, and to avoid sugar, caffeine, alcohol, and spicy and acidic foods. There's a tendency for retention of residual urine. Sometimes you'll get an order to check for post-voiding residuals. So if you get an order on a patient and you're supposed to do a post-void residual, what do you think you're going to do? You're going to catheterize the patient after they've emptied their bladder to the extent that they feel they emptied their bladder. Then you do an in and out cath to determine how much was left in the bladder. So what's it called again? Post-voiding residual. So if you have that kind of a physician's order, and sometimes they order it like in the morning, you just need to talk to the patient and tell them that next time they void, they need to call you, because often they use a urinal, or as often on men because they have a large prostate. So make sure they understand that as soon as they empty their bladder, they call you, so you can come in, do the in and out cath to determine what's left in their bladder after they, as best as they can tell, they empty their bladder. Okay. Endocrine system changes, there's decreased antidiuretic hormone. So if you have a decrease in the amount of antidiuretic hormone, what happens to your urine? It's more dilute, more volume, right? Antidiuretic hormone is the hormone that prevents your fluid loss. So if they have decreased antidiuretic hormone, you have more urine, more dilute urine, and they're at greater risk for dehydration. Already, they're at risk for dehydration because they don't have that sense of thirst. So with this endocrine change with decreased ADH, it even puts them at greater risk for dehydration. As in terms of endocrine, the most common endocrine problem that you're going to see is that they have type 2 diabetes. but at any rate, they have diminished glucose tolerance. Okay? Their blood glucose doesn't return to normal as quickly as it does in younger adults. The onset of type 2 diabetes is greatest, it was always the greatest between the ages of 60 and 70. Now we're seeing young kids, 10 to 15, being diagnosed with type 2 diabetes. What's that attributed to? Obesity, yes. Because if you're obese, you're probably eating too many calories, probably not high nutritious type of calories. So what does your pancreas have to do? Work overtime to produce insulin to counteract all of those glucose calories, all of those sugar type of calories that you have ingested. So pretty soon, what happens? The pancreas gets tired and doesn't make enough insulin, so you end up with type 2 diabetes. Generally, that's reversed once you lose weight, same in older adults. Many patients have decreased thyroid hormone. How many of you had hypothyroidism? And they were taking thyroid replacement hormone. So that's really common in older adults. What kind of signs and symptoms would you anticipate if someone had hypothyroidism? Do things speed up or slow down? They slow down. So what would they have? How about the GI system? They would be constipated. They would feel cold. What else? They're real active and no, they're lethargic. What else? How's your skin? Moist? Dry? Very dry. How about their LOC? Can't think very well if you're hypothyroid, in a hypothyroid status. We're not sure why the thyroid diminishes in its function, just like a lot of other functions are diminished physiologically. Why? We're not sure why the thyroid hormone decreases, but many older adults need to take thyroid replacement. You should highlight, make a little note, hypothyroidism is very common. Every now and then a patient develops hyperthyroidism. And hyperthyroid is just the opposite of things, the signs and symptoms I just mentioned. But it's important for you to know because atrial fib, if the patient didn't have atrial fib before and they suddenly develop atrial fib, it's often the key indicator that they have hyperthyroidism. So in the absence of having had atrial fib before, if they suddenly develop an arrhythmia, the physician will check to see what their thyroid hormone levels are, because it's often an indicator that it's hyperthyroid. Am I doing that? Hi. Your basal metabolic rate declines at 1% per year after the age of 30, and your thyroid determines your basal metabolic rate. So it declines 1% per year after the age of 30. So by the time you get to 60, you've lost what percent? 30%. That's why as you get older and older, it becomes more and more difficult to lose weight because your basal metabolic rate diminishes by 1% per year. And also it's what? Such good things to look forward to. Okay, it's almost time for me to let you go. Okay, what time are you supposed to get out? Wrote it down, so I won't give you 1:45, so I should let you go pretty quick here. Last slide. Okay, endocrine changes. Continue. Okay, in terms of endocrine changes, there are, for both men and women, there are diminished production of sex hormones. Men often develop benign prostatic hyperplasia, also called BPH. And as a result of the benign prostatic hyperplasia, many of them develop overflow incontinence. And this is where they feel like the bladder never really empties. And then they only have the ability to expel the urine that's overfilling their bladder. So the bladder stays pretty full. Overflow incontinence. Those patients may need to have a, what's the procedure called to reduce the size of the prostate? A TURP, we call it, transurethral resection of the prostate. It's kind of like a rotor-rootering out of the urethra so that they can have a better urine flow. Okay, testes decrease in size and firmness for men. In women, there's decreased ovarian function, and as a result of decreased ovarian function at the time of menopause, they often have complaints of vaginal dryness and atrophy. As a result of decreased secretions, they often develop vaginal infections, mostly related to what? Yeast. So many older women may have yeast infections. So in terms of men and women, they have significant changes in sexual functioning, but keep in mind that sexual response is slowed, just like all kinds of other things are slowed in terms of our biological systems. But for both men and women, their response may be slowed, but they continue to function, be able to have sexual functioning up until who knows what age. So it takes longer to become sexually aroused, but it doesn't inhibit their ability to have sexual relations. Okay, your test number 1 is tomorrow. Get a good night's sleep. Study hard. Make sure you have a Scantron that's already filled out. 9 digits, the one on the right is empty. On your Scantron. How long has it been?
Hey, study.